Hey everyone, this is the Nips and Sips podcast featuring me. I'm Dr. Jeremy Boyd and Dr. Brandon Cruz over there. Today we're going to be talking about using manual therapy, not just purely as an intervention, but as an assessment tool. I think we too much limit ourselves as it's purely there just to make patients feel better, but we can actually use it as part of our examination and develop a better plan of care as a result of it. But before I get too much into things, let me pass off to my partner in crime, Brandon. How's it going?
Doing well. Thanks for the introduction, Chair. Yeah, can't wait to really talk about this one. There's definitely a passion of mine, and I think you share the same or similar sentiment. But before we go to that, let's look at our drinks. So I'm actually switching up today. I'm having a Stella, only because I was on a call earlier and I left the house and forgot to restock my bourbon. And luckily, I had random beer in the fridge of my office, so that's what we had earlier. I was on an EPSIG group, so it's early professional special interest group for AOMT, trying to start that up, kind of get younger clinicians, third years, first couple year clinicians out, and even some seasoned clinicians that perhaps want to do a fellowship or get involved and kind of start a platform for those individuals. I know, Jerry, you're involved in it as well, though you weren't on today's call. So that's what I was doing this morning. And what about you, Jerry? What you been up to?
Just been working on some projects for the clinic and everything like that we have got going on for the next couple of weeks. But yeah, very interested and excited about that group. And yeah, as we mentioned before, those first couple of years in a new grad career is kind of sets a tone for the rest of your career. So groups like this can help with mentorship or just being around like-minded individuals. But what I got going on today is a Mango Kush wheat ale from the 420 strain of Sweetwater. I've actually got a couple 6-packs of this. I'm a huge, not a big flavored beer guy unless it's mango. There's a couple other flavors I do actually enjoy, but mango and beer I think just work together. So yeah, I got some 420 vibes to it. What I'm going to do differently now, I'm going to crack the beer open now. And now I'm going to start rating it like the Barstool guy.
Okay.
I'm going to do my own version on tap. I've had a couple of these. I'm a big fan of this beer.
Is that a sour beer?
Huh?
Is that a sour beer? Most mangoes.
No, it's a wheat ale. It's just a wheat. Yeah, it's super good. I'll save you one. I'm drinking out of my themed cup here.
Cup.
Got this in, huh?
Said your chronic cup.
My chronic cup. Crush, feel it, it fit well. I got this in Montreal. How to get at that place that we were all recovering at. Yeah, it's definitely got some hemp smell vibes to it, but this is
Nice.
it's refreshing, especially today. It's like 80 some odd degrees outside, so mango is just a perfect touch. I give this 8.2 on my on the Jeremy Boyd scale, 10 being the best damn beer I've ever had. Huh?
Like a pain scale.
Oh yeah. But we're going into decimal points because I think it's going to get that tight towards the end. Really good beer. Don't know where Sweetwater is in all honesty, but I picked this up at the liquor store. So if I ever get a chance, I'd love to stop by. But before we go crazy with the beer there, let's talk about using manual therapy as an assessment tool. I know it wasn't something I started off my career doing. It was purely, special test and my objective exam or range of motion, pulled out the goney, let's do everything. Spend 20 minutes doing ankle range of motion measurements. And then, I'd get some joint play assessment in. And then after that, I would say, hey, maybe I'll have some time to do some manual therapy that I think may work. Or if I was crunched for time, give them their home exercise program, and off they kind of went. Probably did not do well for me in a terms of carryover or, people actually attending that second session. So luckily, we were exposed to this in residency. where we can do some manual therapy. A lot of our assessments or especially our joint play assessments, can be converted into some joint mobilizations as long as you take the time, and you're specific with what you're trying to do. You can make an impact right there and then. So it's an awesome thing to start to get the client to buy in within the first couple minutes of your objective exam. But let me pass it off to Brandon. I think we're talking a little bit too long.
Yeah, I think we rely too much on that pathoanatomical diagnosis, and as you alluded to, those special tests. You and I both take interns pretty much year round, and see this a lot in new grads and entry level clinicians and resident clinicians that are early on. Relying too much on those special tests. And what are those special tests designed to do? It's to try and give you an indication of what's going on. But when somebody comes in, let's say with, knee pain, and
Oh,
you're thinking, all right, let me test my ACL or test my meniscus or test IT band syndrome or whatever. Why are you testing that? What are you really looking for? And where I've, I guess gone to and evolved as a clinician is I'm trying to gauge my patient's response to treatment, because at the end of the day, that's what really matters. It doesn't matter what diagnosis they have. What matters is, can I provide them relief, and can I, provide them more than relief, which is to get them pain-free, permanently, or, introduce new movement patterns and et cetera. So that's where, my response to treatment comes in more than, their diagnosis. I don't even care about the diagnosis half the time. I'm like, okay, go on the table, tell me your story. I shouldn't say okay, because I'm not brushing off the patient, but, they tell me their story, but then it's like, all right, let's see if you feel better with this, because what if that knee pain is just referred pain from a stiff hip, or a
mhm.
referred pain from, hypomobile hip lacking, 20 degrees of internal rotation, or lacking a posterior glide, or maybe it's coming from the lumbopelvic region. And you wouldn't know that unless you did your spring testing / a manual intervention. And that's kind of what I want, this episode to be about, is how to get there. And I also know that, also comes with, pattern recognition and some experience, but hopefully the younger clinicians, and even maybe some older clinicians that maybe are stuck in their old ways, can, take a step back and look differently, and how we can use it to diagnose it and prognose. But yeah, with that, Jared,
Yeah.
how do you use it in terms of diagnosing, in terms of replacing or putting emphasis on that pathoanatomical position? And I know you had also talked about an article that kind of helped you with some initial framework early on in your career.
Yeah. So yeah, I'm kind of went down that same route. I was very pathoanatomical when I came out, and I thought that was the best part of being a physical therapist or anyone in the orthopedic realm, is you get fueled with all these diagnoses in PT school. You sound badass when you can say them correctly without screwing up like spondylolisthesis and those things and all those sort of things. As it made it made you feel kind of like, oh, wow, I know what I'm talking about. And we know with all these studies of asymptomatic individuals and those sort of people with pathoanatomical diseases or illnesses, or diseases or conditions, that they're asymptomatic even with them. So yeah, making that transfer of like not putting as much weight or taking all my diagnoses with a grain of salt was a big shift for me. At first I was like, no, shouldn't we be as, I guess, smart as we can by providing these ultra detailed diagnosis? And in all reality, that doesn't really help anyone. Sure, they may have it, but what's 9 out of 10 people going to do in this information saturated world? It's just, they're just going to look crap up. Most of your stuff online is horror stories. That's going to feel more into their, if we're going to down that pain science rather than central sensitization and kind of hyping up the nervous system. So kind of getting away from that and just treating the client again over the diagnosis was, a big a huge thing for me. Let me share that thing. It's called the script. I believe it was either in a residency or Ernie Gamble, uh, one of the owner of the last clinic I was at. He gave it to us. So it stands for the Systematic Clinical Reasoning and Physical Therapy. So it was a good tool to kind of force you to think outside of just where I first worked. Is purely, there was no direct access. It was purely whatever the physicians were saying. We were part of a hospital-based system. So it really didn't take much skill or anything like that. It was just like, all right, follow the rules, impingements, pec minor releases, some scap work, and that was it. You know, patellofemoral pain syndromes or chondromalacia, just work the hips and the quads or something. So it didn't take a whole lot of skill, but this this tool is a tool to kind of help kind of guide things along. I won't go through all of it. I know it's mentioned in some fellowships. I believe EIM. I know Baylor uses this. I think this was developed with Baylor. But just kind of illustrates how you can use this model to kind of help guide you into more of a higher level of thinking. I'll kind of go over to the stages here. But these are the how to use it. So the patient completes their profile and their body chart just like they would at pretty much any clinic, at least I hope in every clinic. You're going at least over a body diagram. You fill out their first section of the script, which you start to formulate and prioritize early hypothesis. So based off of what they're just purely writing, you should already develop kind of a hypothesis. Then you complete a patient history with the client, and then you reprioritize your hypothesis. Then you start to fill out a couple little sections of potential some history influences, and then you conduct your physical exam, and then you reprioritize your hypothesis. So you can see it's just constantly shifting around what your hypothesis is by each stage in the game. And then before you can have, obviously, if you're in a fellowship or residency model, you kind of discuss with your mentor or your mentee what you think is going on, what the plan of care is. Me and my residents or student physical therapist, we have a big conversation after that, the subjective interview. And I'm like, all right, what are your primary, secondary, tertiary hypothesis? Because we are mostly a direct access clinic. And then they're able, I'm like, all right, based off of that, what do you want to look at? X, Y, Z. All right. And then after that, I'm like, all right, what do you firmly believe is a diagnosis? And we discuss it. I'm like, all right, well, test some things out, try and see if we can make it better right here, right now. So before you finish things, you can further screen, treat, or refer. And that's kind of that big piece, is you can start that treatment before you're all said and done. But this is kind of how it goes. This is right after the client fills out their body diagram. Then it moves over this is your planned exam procedures, what you plan on it being for the next couple sessions. So it kind of like outlines some things. But yeah, it's a cool tool. I don't so much use it much anymore. Just personally, I'm not writing all this down. But it was a good tool to kind of start off things and kind of get you in that mentality of, I have to think of what it is based off the information I have. But another step or tool would be like, maybe a step in that would be better. Be like, were you able to modulate and change the symptoms with some sort of objective during your objective exam? I think that would be the best thing if they can add that.
Yeah, and I want to add to that, because I think of that whole thing, and obviously this stuff happens in an evolution. We can't expect new grads and early clinicians to have that type 1 thinking, that pattern recognition, that advanced type reason, because we're relying a lot on experience. And for what that is those experienced clinicians, especially expert clinicians that have gone through, especially the advanced training. We know what we rely on is how somebody has responded to a previous treatment.
Mhm.
That's where we're able to cut that corner and then see, hey, does this, all right, the last 10 people I've had with low back pain responded to a manipulation. I'm just going to try, once I clear out my red flags, I'm going to try manipulation, see how the response. And that's what we're talking about here when we're looking at can we use manual therapy for a diagnosis or prognosis? Because standardly or typically, especially in school, you're taught the stepwise manner, or even the script. I don't want people to get hung up with a script. I want people to be able to ebb and flow in and out seamlessly. 80% of low back pain doesn't have an accurate diagnosis. It's non-specific. So why are we trying to do all these special tests to figure out a pathoanatomical diagnosis? No, the goal is to take a special test or even a treatment to see how they're going to respond to that. We're taught, especially in entry level school, or at least most programs, and I understand to a degree it needs to be taught this way. You have your subjective, you do your special tests, you have an assessment, and then you develop your treatment plan. And with that treatment plan, we have to come up with a diagnosis and a prognosis. But how are we going to know a prognosis of we need to see them 2 times a week or 3 times a week for 6 weeks and they'll be better? How do we know that person won't respond very well to manipulation, patient education, and 2 exercises, and they'll be better in 3 sessions or 2 weeks? And you don't know that unless you perform that manual therapy as your assessment. And that's where I think people really need to be going towards. And I know there's this movement of CPRs, and are they dead now? Especially I think even this past year's at AMP conference, Chad Cook, and he's made a few CPRs in his day. Are they dead? And I don't think they are. I think the goal of a CPR is to try and determine what subgroup of patients are going to respond to a treatment. I think that's supposed to be where we start, not where we finish. And if it's where you're finishing, then yeah, that is dead. If you're using it as a starting place, then they're not dead. It's just giving you an initial framework to build off of, and then we go from there.
No, that's perfect. Actually, with all this talk, I decided to pull up what I presented at CSM 3 or 4 years ago, maybe 5. Shit, I'm getting old. Of how we kind of use that platform of using manual therapy, and we essentially finished up the client in 3 sessions. Could have been even quicker, but just to backtrack and going off of what you're saying of like how those experienced clinicians can cut corners because of essentially experience of like, all right, I worked on Jim and I tried this, that worked, and then I'm working on Jane. Jane's kind of like Jim. I can try something like that on Jane, and then 3 years down the line or something like that, like you got Bob who kind of presents like Jane but needs his own little spice, and you tried something with Heather and you're able to kind of combine things and evolve. And that's the beauty of mentorship, especially in-house mentorship, where it can be evolved right there and then. Is the mentorship just cuts all those corners, starts to cut all those corners. Like, oh yeah, it took time to figure out that Jim, Jan, Heather, and Bob all were kind of similar. Now it's just like I have a resident or I have a student or I have my PT in-house. I'm like, all right, I'm going to tell you what worked for Bob after my caseload or my population of N of 100 low back pain patients. They respond to this. But I always like to see what the student or resident, what they offer first. I'm like, all right, that's great. And they know my approach of, implementing manual therapy as part of the examination. I'm like, that's a good technique, try it. But, based off of certain things I see, they also may benefit from that. And they're like, why don't you try that if that technique didn't get all the way there? And more often than not, because of that experience value, it tends to go that way.
Real quick, Jared,
pull up. Go ahead.
Cutting corners. I'm just saying, I don't think we should say cutting corners. I
Not
think
cutting corners.
We're just expediting that process.
Mm-hmm.
And how
better word.
Yeah, they're going through it, but instead of taking 3, 5, 8 years, you're learning that in a year or two.
Exactly. And certain things, and we're talking about objective exams and stuff. Um, I can say, like, especially with mine, like a good quarter or something of my objective exam is purely made up. Like, there's no books, research, things like that, where I could, you know, find that. It's all like, all right, let me test these things out. We talked about the shoulder symptom modification procedure, and it has its thing. It's really good for buy-in, but a lot of what that is a manual placement of hands or shifting things around and seeing how that can, lower their pain with something that we can compare it to, forward flexion of the shoulder. Taking that principle and applying it anywhere on the body, I think was the best thing that whole article or Jeremy Lewis's work gave me. It was like, all right, I have a athlete that hurts to squat. I can screw around with their kneecap, putting it in any position as they squat, and all of a sudden now they went from 8 out of 10 to 0 pain with just me manipulating the patella or the ankle. There's been times where I've added more of a dorsiflexion component to it, and now it's pain free. That stuff isn't exactly research or anything like that, but that creativity of using your hands, applying manual therapy, or I think there's an issue. Maybe I'll move their ankle for a little bit, 2 minutes, and then have them hop into that squat now, and now it's pain free versus me being there doing the whole thing.
Two questions here, or two things. So first, you learned a SNSMP on the shoulder. How long did it take you to do it on the shoulder, and then that light bulb kind of go like, wait, I can do this to any joint? Because the article just talks about the shoulder, and I think that's the thing. Like, people are taught that you're given an example of one thing, and then you just do it for that one thing, and then for I don't know, it varies for everybody. But then you realize, oh, I can do this here, I can do this here, I can do this here, and you're not tied into that box. And I think that's what I'm trying to convey out there, is not being tied into a box. But when you understand the principle, you can then apply it towards whatever.
Yeah. Or another principle that I think we talked on the shoulder on the show is cervical mobilizations with nerve glides. I think that's research, but not so much in the lumbar. It wasn't like, all right, what's holding me from actually experimenting with that? Nothing. Yeah, I only need an article to reference, good practice and try and make my patient feel better right now. But when did that happen? I think I fully kind of flourished into it when I started Trifecta, but probably dabbled with it. It probably took me at least 6 months after learning it. Maybe I'm trying to think of, like, I remember the knee vividly. It was just like, I would just screw around with the knee just like I would do the shoulder. I want to say maybe 6 months to a year after that. That's when maybe a more basic thing like a knee, I'd do it. Okay, the knee works. That's easy. And then I was like, wait, I can do this anywhere. That maybe took like 6 months a year. I don't know. Maybe I'm.
Yeah, no, that's fine. It doesn't have to be exact, but I mean, we learned that in 2014, right? Something like that. You took it for a year. That's 2015. You opened Trifecta in what, 16 or 17?
End of 17. Yeah.
So now you're looking to really hone into it. And hopefully people listening to this, it's like, all right, maybe it's that green light where they can expedite that process. And instead of taking them 2 years to fully dive into it, it becomes, 6 months. And I want to add to something. I hope I'm not throwing you off on your thought process.
No, go ahead.
With that, 2 different points, because I think a lot of people go into, okay, there's pain at the knee. And let's say they just did something at the knee and they didn't look at the ankle or the hip, and okay, they're just going to rely on a special test. A special test is so limited. I mean, they're just shitty. So, you being able to go down that road of let me try this. I mean, you only get that. I shouldn't say you only get that with your hands, but basically trying to see a patient's response to treatment. And while we're in COVID, let's talk about virtual. All right, you can't put your hands on somebody, and for the this doesn't work for virtual PT. Yeah, it does, because at home, have the patient elevate their heels, have them elevate their toes, have try a modification whether it's manually or not, and see how they respond to treatment. That's going to then give you a clue on what you need to do.
Absolutely. And yeah, I've done some of these techniques over virtual. I'll be like, all right, I've even had someone play around with their kneecap with a squat. I'm like, all right, try and show them mobile, like a self patella thing. I'm like, hold that there as you try and like sit down. And they're like, oh, it's a little bit better. So little things to help them out. And another thing on special tests is, what do most special tests do is they're provocative, most of them, or at least a chunk of them.
Yep.
So they're more likely to piss people off. And I know, especially, it's something I may have struggled with early. I think every student does, is those clients that come in and they're pain free, and they're like, oh, by the time I came in or doctor came in, I don't really have any pain today. And it's just like, well, I gotta find something. And I guess the goal is like do like really hard resistive tests or some of these special tests and cook them up even more. I mean, that's not ideal. I wouldn't recommend it, but if that's what you need to kind of find some things, yeah, it's okay. Now you may have found some more information. I doubt it, but you better do something to fix it right there and then, because they came in symptom free. You did some special tests to piss them off, and then what? You're just gonna be like, oh, well, I figured out what's going on, and I made it more worse, but we'll deal with this in the next session. No, at least try and make it better. But ideally, we're trying to, not piss them off, make them feel even better. They probably have some motion problem still if they're coming into you, and then addressing that. Or a lot of times, with our, hands-on or palpation, yeah, they might have hip pain or something like that. In those situations, they come in, they're symptom free, and then you doing, oh, what the hell, I'm going to still do a thorough examination. You're already here. Let's, most of those individuals have had their pain on and off for a while. That's why they finally decided to get it checked. All right, let me put you through a thorough examination. And then you find out just with your spring testing or something like that, it's something in the thoracolumbar or something like that, or in the lumbar spine, and that's reproducing their hip pain. And you're like, all right, well, actually, it's something that you may need to work on in the back. So, those are certain things, the beauty of being able to actually do those sort of things. Yeah, what was I going to do? Huh.
Yeah, see, I know I got you off track here.
No, it was good. Here we go. But we'll talk about.
Oh, there it is.
I know you. This is old school. I'm trying to make another one for AMPT. But this is what I did in residency, but using this same model. So it started off, applying what we're talking about, but probably at a slightly lesser level, with my client. I remember we got his client had about pain for, I believe, a little less than 2 weeks. Had a previous history of C5, C6 herniation, some impingement stuff. I remember I had my student, Tony Gam. He was my first student. I remember this guy really wanted to come in, and it was like half an hour past what we would normally work. But I was like, screw it, we'll stay. And I remember seeing his paperwork ahead of time, and we used focus on therapeutic outcomes. And I remember seeing this, and with my it was this and maybe a couple other things. Didn't see I had any past medical history. And with just this, so kind of using that script model, I was like, I bet you there's something wrong with this, C7, lower thoracic spine, just on the referral pain pattern. I was like, I remember telling Tony this, I bet you if we hit that, he's going to feel like $1 million. So obviously I was biased towards it. So, but that's exactly what we did. Like, we did some examination. During the examination, joint play or mobilizations of a C5, C6, C7 reproduced his pain more towards his shoulder. So that kind of confirmed things. So, long story short, did the CT junction. I think I did mid-thoracic mobile manipulation as well. maybe, and threw some mopes to kind of start off, and it went from a 6 out of 10 pain, and I think he went all the way down to 0. Second session, he had like a 1 or 2 out of 10 pain, repeated the intervention. He was completely symptom free. And then the third one, he was pretty much just coming in for a discharge follow up. Here's what you got to do to make sure this doesn't happen to you again. But that was using that kind of mind framing. So I had an idea based off of, experience, residency training, but what the objective doing the palpation or the mobilization, that confirmed things of, and pretty much that examination did not take long. One, because it was already working overtime. I was like, all right, I see this here. It seems a little stiff. Let me do a couple of quick manipulations or techniques. And he was better right there. And I think we evaluated him within like 30, 45 minutes. Everything else.
That's a great, I guess, story or case, the way you presented it, because you saw this objective, you took this objective, you recognized the pain pattern, you recognized it was a somatic referral from the lower lower cervical region. You didn't do a bunch of special tests. You said, okay, I think it might be from here. Let me just assess it real quick and provide an intervention and see how they feel. If they feel great, cool, I know I'm on the right track. If they don't, all right, now I go back and check some other things. But, and that's what we're taught here, if you guys can see, examination, then do your evaluation, then do make your diagnosis. Then you're going to say, okay, based on this diagnosis that's pathoanatomical, we're going to say this is our prognosis. Then we're going to do our intervention and see how somebody responds. When you could cut all that stuff out, and if you have an idea of where something might be, just try and do whatever that intervention would be ahead of time and see how they respond. So, why have that old way? And then, that PowerPoint there is from my Regis Fellowship, and you and I obviously were doing it before, but I think obviously we refined it with time. And for me, it was really refined and even put into words so I knew what I was actually doing when I went through my fellowship. And Cam McDonald made this, and that dude's a genius, and I love my time with him. He's awesome. But he puts it in great words here that, the prognosis is a prediction of the course of duration and outcome of a disease, keyword, based on the pathogenesis, another keyword, of the disease and the presence of risk factors for the disease. It is established after the diagnosis is made and before the treatment plan is established. However, for us, what we do, that is where the problem lies. We are not medical physicians. We are not trying to just give somebody a diagnosis and send them out the door with some drugs or an injection. Our job is to find what modifies their symptoms or what they respond to then, have them improve their quality of life and all that other good stuff, or have them live pain-free or impairment-free or whatever the case may be, and not have this emphasis on disease and pathoanatomy and pathogenesis. And that's where, we have that hybrid, we have the best of both worlds, but we need to not really just focus in on a diagnosis. Because, Jer, if you had to give that case of yours a diagnosis, what would you even give it? A radiculopathy, maybe?
Yeah, I guess so. I would love to have those notes with me, but I think I left it as like non-specific referral. Yeah. Didn't need to go into the weeds of it. Didn't need to refer out or anything like that for a formal diagnosis. And he did great.
The guy he didn't have a diagnosis? No, he probably just was relieved that you got rid of his pain in 20 minutes.
Yeah, that was it. He was loving it by the time he left. So, and we talked about this with Manuel. Did he need it? Those sort of things. So yeah, he went 2 weeks without getting any better. He was exercising. He was in the gym. He tried doing stretches. Didn't get any better. And then we did a couple of quick techniques and went on his way. And yes, I know in the fellowship model, they would say, hey, you should have fixed him in 1 to 2 sessions, but I was a young bull. No, it was a good case to kind of demonstrate those sort of things. And and he referred people to us all the time as a result of it. So
I have kind of a marketer for life, someone who's going to just spread the good word of, you need someone to go get fixed. Jeremy's your guy. So.
Mm-hmm. So he wrote us a nice review from what I remember, I think. So,
Nice.
but yeah, I mean, is there any other nuggets there?
No, I think that's it without just kind of rambling on. I mean, obviously there's more to it. This stuff takes time. If you have somebody who's gone through this process and has higher level thinking, um, it's going to, only help that. But I think there maybe just some key concepts to kind of wrap up with.
Mhm.
It's embracing and to give credit before I continue on. The slide I showed, like I said, was from my fellowship program. Cam created it. It's called the dynamic wheel. It's basically saying how we need to not think linearly, but understand that pieces can be intertwined and moved around, and you can jump ahead and do an intervention before you go and do a full exam. I
Mm.
think he had a saying, and hopefully I don't butcher it, but something he tells his entry level students, and when he, I guess, took interns and stuff, is his expectations of an entry level clinician is to be able to perform a full and thorough evaluation, but they won't need to do it, or they won't always do it, something along those lines. And basically is you have the skill set and knowledge to perform, that in-depth evaluation that we're taught in via textbook and via school. But to be a good clinician, you don't need to. It's knowing when and where and how to, plug those pieces in. So I just wanted to, say where and what this is from, the dynamic wheel from Regis University, and not take credit for that. But it comes down to embracing those three elements, and we've talked about this multiple times on our show here. Evidence-based practice, the three pillars are patient values, clinician's experience, and the research. But also utilizing test retest. I think that's the biggest thing. Find the asterisk sign. Find a technique that makes them better. Like you were saying, those special tests are a lot of times provocative. All right, maybe use a special test to provoke symptoms. Then you do a technique. Then you do the special test again. Did it get better? I think that should be our litmus rather than trying to find a pathoanatomical diagnosis. But anything else to wrap up on your end, Jer?
Yeah. No, and if you do things like that, you can afterwards, and you kind of steer away more from the special tests or rely on them or diagnosis or those sort of things. And you can have an idea of like, oh yeah, this person probably has a meniscus tear, but well, what's the value in doing the test just to further confirm that or anything like that? But you can actually spend more time investing in how to make them better. And then afterwards you can say, hey, when people ask you like, oh, can you fix meniscus tear? Like, yeah, I've had a lot of them without the need of surgery, especially if they get into your hands first with certain things. As you can say, hey, I can fix a meniscus tear without operation or lumbar herniations or cervical. So with spending more time trying to make them better. Obviously, there's a place for special tests, and especially ruling out red flags, or dealing with people with acute trauma or those sort of things. There's a place for them, but let's face it, with how most of us are in practice in those sort of things, we're typically getting these people a little bit later down in their road. So if you can be the one that figures them out ahead of time, and especially individuals that have gone through the medical system multiple times, other PTs, chiros, physicians, I think we need to do more of this to be the final solution for them. So, but yeah, no, that's the last little thing I had to say about that. Wrap up my drink here.
Very nice.
8.2. Finished yours?
Yeah, and I'm saying, how you feeling with your 420 edition there?
was good. It's good. It's a little bit lighter percentage compared to some, and usually I get the was it the 16-ounce cans, and this was just a standard bottle of, I think it's
Mhm.
only 5%. So I feel pretty solid. Usually those big cans and they're 9% by the end of the show. I'm like, all right, let's wrap this up. But no, yeah, it's pretty good. It's a highly recommend. But yeah, if you guys have any questions or concerns or need help of any sorts, feel free to reach out to us at Nips and Sips on Facebook and Instagram. Our podcast is available pretty much every major platform of iTunes, SoundCloud, Spotify, and all the other ones. Our episodes are now going up on YouTube. That's also at Nips and Sips. If you have any questions specifically for me, I'm at The Decent Doctor at Trifecta Therapeutics, and Brandon's at Think Like a Fellow and at Pursue PT Now. Thanks for listening in, and yeah, cheers, everyone.
Here's guys.